All right. So as discussed or as promoted, I'm going to talk about too fast. Prostate cancer ablation. So this is a topic that is near and dear to my heart and has been growing in interest and popularity around the world. And I think it's important to emphasize that this is a new technology, but the goal of this is really to personalize patient care. So it's not for everyone, but it is an option for personalizing care for the men that we treat. Um, I do have several disclosures. The most relevant one is Profound Medical. They make the Tulsa device. I'm on their clinical advisory board. The others are not as relevant for this discussion. So, who is a candidate for ablation? So, we're going to review some of the anatomic considerations and discuss what are the patient goals of treatment. Those are really the main things that inform whether or not an ablation therapy should be used, and then also what type of ablation therapy. What are the ablation technologies that are available, specifically at Yale? And then also a little time, hopefully at the end, for the residents to kind of practice patient treatment selection for some folks. I think that is really the best way to learn and understand this. So, kind of what is ablation? I mean, patients or say oblation. A lot of people say oblation, but it's ablation. Ablation is destruction or a process of ablating, such as surgical removal, according to Merriam-Webster. It also is associated with icebergs, but we're not going to talk about that one. If you do a Chrome AI search, ablation is surgical excision, cryoablation, this removal or destruction of tissue or a body part. And it can be used by various methodologies. So really what we're talking about is how do we take the cancer cells and destroy them? That is the goal of these therapies. And ablation, a lot of people say focal. Like focal is one of the parts of ablation therapy. It is not the only. Ablation is a category of tissue destruction. So why consider ablation? Well, really, it is the promise of precision. We are trying to minimize the collateral damage to normal tissue and things around it. If we have this young guy, we want to get rid of that apple, we're not going to come at it with a wrecking ball, right? We're not going to take the whole kid with it. We're going to be more precise if we can. And now, especially in the era where patients are consumers, there's a ton of information on social media and ways for patients to do their own online research. They want active involvement in their care decision. The paternalistic kind of healthcare physician still exists, but is not as popular, especially among the younger generation and men in the millennial generation who are going to be developing prostate cancer in the next 5 to 10 years. They want to be able to choose what they are being involved in. And many of them are interested in new technologies, as that is a large part of our life these days. Which pill do they want to take? They want the choice. So this has been an evolution. So radical excision for local control, Halstedian, we were taking out entire organs. So in the liver, we used to do a hepatectomy, and a partial hepatectomy. Kidneys, take out the whole kidney. We used to do radical mastectomies. This has evolved towards precision medicine, where as we have been able to identify the tumors within these organs, we are then treating just the lesion. So excision, but also for all of these other tumor areas, there is ablation. So there is cryoablation of the breast cancer. There is cryoablation RFA of kidney tumors. There is ablation with RFA, IRE, HIFU, like many different things in the liver. So what about in the prostate? Well, we know that about 80% of prostate cancers have an isolated index lesion. So the only cancer that we are worried about is in one place in about 80% of prostate cancers. And with the utilization of MRI and targeted biopsy, we have over the last 10, 15 years, we've been able to accurately localize prostate cancer with more accurate grading and staging of this disease to allow us for more appropriate and precise treatments. So we can see where the cancer is. Is it in the anterior part of the prostate? Is it in the posterior part of the prostate? Is it near the neurovascular bundle? We have a much better understanding of this anatomy through our significantly advanced imaging now. So these young men or middle-aged or older men ask, why do I have to treat the whole prostate if you know where the prostate cancer is? This is what they ask me in my office. And, I sort of agree with them. Why are we still treating the whole prostate if we know where the cancer is located? And this has been and with the MRI, we can see where these tumors are. We biopsy them with that targeted information, and we can confirm histologically the location of these cancer cells within the prostate. And in fact, many people have been asking this question for quite some time. It is not just sort of focal ablation. Focal ablation is just the most recent extension of this. There are trials and studies that have evaluated focal brachytherapy, so radiation. There are therapies. We had Dr. Menon come and speak with us that in surgical partial prostatectomy, treating just the anterior part of the prostate, treating just one side of the prostate, and Indigill. And so this is not a new or unique idea. An important thing to recognize, though, in the context of trying to do a focal therapy or treating just the area of the prostate cancer, is that MR imaging is very good, but it does need confirmation with biopsy. And even then, there is a significant amount of cancer that is outside the visible lesion that we see on MRI. So it is advised. There have been multiple studies. There are now companies, I'm not going to go into it, that are using AI combined with pathology to give us a better heat map of where the cancer is located. But in general, we want about a 1 centimeter margin around the visible lesion when treating prostate cancers to be able to make sure we're getting about 94% cancer control. With some of these new AI models, we can get much higher than that, about 96, 98% cancer treatment. So what are the prostate cancer ablation technologies we have at Yale? It's great to have a full toolbox. That means not everything has to be a nail, right? We don't have to use a hammer for every procedure. We can use IRE, we can use HIFU, we can use cryo, we can use TULSA. They're different. They are different tools. They're all a little bit different in their abilities, their strengths, and their weaknesses. And that's what we're going to talk about a little bit today. Some of these have been around for a long time. Cryoablation actually got FDA approval in 1991. At that time, it was pretty much whole prostate cryoablation. There were some studies looking at hemiablation based on just pathology information. But this then evolved. RFA, radiofrequency ablation, laser ablation, IRE, wasn't for another almost 20 years later in 2011. HIFU in 2015 got soft tissue ablation approval, PAE for prostate tissue, TULSA in 2019, and then microwave ablation in 2024. So there's been a steady evolution and introduction of additional technologies. There's been a shift. So this, sorry, the colors aren't too distinguished, but the left column was publications from 1996 to 2015. And then the orange, which is the right column, was 2015 and 2020. HIFU exploded in that period of time. There's a huge difference. The technology was approved. And so since 2015, when it got its approval, there have been a great amount of interest and use of HIFU, especially in Europe, but then also in the United States. Cryoablation dropped off. It was kind of the old dog. It had a lot of publications, but it was old, so people didn't necessarily publish about as much. But you can see there are a variety of these, and this was a study from 2022, just review looking at this. So let's talk about these different ablation therapies that we have. So, and also please be interactive. If you guys have questions, stop me. I'm trying to kind of go at a pace where people have time to digest this, but there's time for questions at the end, but happy to discuss it in the middle as well. So cryoablation uses freezing, and this is a needle-based technology. So there's sort of needle and ultrasound-based technologies are the two main current ways we treat with ablation therapies. Cryoablation uses freezing to induce cell death by dehydration, protein denaturation, and rupture of cell membranes with crystals, as well as vascular stasis. So the very important, this is a freeze-thaw cycle. So you have to freeze the tissue, which dehydrates it. When you thaw it, it actually, the inrush of fluid into this solute dense cell is what causes the lysis. And then freezing it again is very effective. Usually do two freeze-thaw cycles. You guys who have been in the cases with me, this is because there is a curve. One treatment ablation gets you about 80% of treatment success. You get to 2 and you're up in the mid-90s. 3 only gives you 2% additional cell kill or so. So really 2 is sort of an optimal treatment. This is done with a transrectal ultrasound. The needles are placed transperineally. The introduction of a urethral warmer has significantly reduced the morbidity of this in the sense of rectal urethral fistula. So And then, but the main limitations are that because it is ice, it has just the thermal properties of ice. For us to get the minus 40 degrees centigrade, which is our target temperature, we need about 5 millimeters of ice ball outside of that kill zone. So we have to do an extensive margin when we are treating these patients, which could put into harm's way the nerve bundles, the rectum, and the urethra if we're not using the urethral warmers. Looking at these on ultrasound is by ultrasound, real-time ultrasound guidance. This is a really terrible picture of an ultrasound. I apologize, I didn't find a better one. But what you can see in the top left, that's just the needles coming in the sagittal plane. And on the right side, the needles going in on the axial plane, these white dots on the ultrasound. The bottom is the leading edge of the ice ball. So we treat from anterior to posterior. We don't treat all at once. And that's because your visualization is obstructed by the leading edge of the ice ball. On the lower left image, you can see the ice sort of moving down, and that's just the index of refraction between the density of the ice and the density of the prostate tissue. But that ultimately, you'll follow that down and establish your posterior margin. Any questions about cryo? All right, on to IRE. So IRE is irreversible electroporation. This is also called NanoKnife. That's the brand name. The only company right now that has this in production is AngioDynamics. It delivers high voltage at a low energy electric current to destroy tissue. And what it does is actually it's irreversible electroporation. So some actually medication delivery is reversible electroporation. You pass an electric current across a cell membrane and it opens up the cell membrane and it can allow you to put medication in. So this is actually one of the ways that we actually treat prostate cancers or other cancers. But this is irreversible. It's trying to not allow that cell to recover and hold anything inside of it. It's killing the cells. By just killing those cells, it maintains the connective tissue matrix, which preserves vessels and, importantly, in prostate cancer, nerves. And really, there is no or minimal thermal energy, and depending on what the amperage you have your ablation at, can really have minimal thermal energy, which is important because thermal energy is what can cause coagulative damage and other damage to surrounding structures. This is a transperineal, also needle-based therapy, where we put needles in through the perineum, rectal ultrasound to help visualize the prostate, deliver multiple pulses. Typically, it's 90 to 100 pulses with transrectal ultrasound guidance. It has a very precise margin of treatment between 3 and 5 millimeters. So it's not like cryo where you have to treat, but you have 5 millimeters of damage outside of where you're treating. This is a very precise margin, which allows for more control and confidence when you're treating near the nerve bundle or posterior along the peripheral zone. And there is some evidence that it actually, because of that nerve fiber preservation, or even if it causes damage to the nerve cells, the nerves regrow. So they did studies in rabbits where they ablated the rabbit's sciatic nerve. Within 7 weeks, the nerves had completely regenerated and were giving full signal. So that's all animal models. We're still waiting for the human data, but it does seem to be playing out clinically in some patients. So ultrasound ablation with HIFU. So there are two different ultrasound ablations we're going to talk about. HIFU is one, the other is TULSA. HIFU is a transrectal applicator. So you can see the picture here. There's a probe in the rectum. It does both visualization and treatment. It uses high-intensity focused ultrasound waves to generate heat and coagulative necrosis within the prostate. It uses a focus beam. It can treat up to 4 centimeters. That's with a new one. It is no longer used for whole prostate treatment. It was for a period of time, but anytime you start getting over just the sort of peripheral zone, many of these guys were getting TURPs surgically beforehand because of the limited efficacy in anterior part of the prostate. These can generate cavitation, which actually can block treatments. These are microbubbles that can occur. And it also can be limited by calcification. So cavitation, anything that's going to block that ultrasound wave from propagating into sort of past that point is going to limit the ability for us to treat that. Interesting, there's a new company called Histiosonics. They are not in the prostate cancer space at this time, but they actually are doing the opposite thing. It's non-thermal, and it's developing those cavitation pockets to destroy tissue. There's actually a clinical trial active at Yale right now in kidney. So if anyone has a kidney cancer patient with a lesion that's under 3 centimeters, ideally around 2.5 centimeters, there's an active trial being run. Mike, are you co-investigator on that, or?
I think so.
I think you might be. But Sandeep Arora, one of our collaborators in the Tulsa program, is running that. If you have any patients with solid small renal masses, this is a really interesting technology that is completely non-invasive, meaning that everything is done from outside the patient and it propagates the waves in. It's non-thermal. So if you have patients, please contact me or Dr. Leitman for this is for kidney cancer, off topic. But it's an extension or similar to this technology. But HIFU has sort of a mapping technology for the targeting where you see the prostate, you map out different bands of therapy, and it is able to then heat that tissue and cause treatment and destruction of the tissue. So HIFU, I'll let the video run so we can kind of talk through that first, but it's done inside an MRI scanner. So it's incision-free. There's no energy that's actually touching the rectum. It is a transurethral device. So the ultrasound probe, the active probe, is actually the device that's in the urethra. It sends these ultrasound waves out from the urethra. It is monitored in real time with the MRI and MRI thermometry. These ultrasound, I guess, HIFU boxes can rotate around and cause thermal coagulative necrosis. The temperature is a little bit lower than what we see with HIFU, so there's less of the cavitation and less of some of the thermal damage to surrounding structures. Because of the real-time feedback, it adjusts the ablation temperature throughout the treatment to make sure that it's getting an adequate temperature, so it doesn't overtreat, but it also doesn't undertreat. They now have, everyone has AI treatment planning. What actually does make the treatment planning a little bit faster. The physician controls everything. We're at the console controlling everything as we are doing the treatment. Really the limitations of this is that it's in gantry. So you have to be doing it inside an MRI scanner. And it also can be blocked by calcifications, as can any ultrasound. Yes, Dr. Ghali.
It's thermal, but it's thermal being emitted from the probe that's in the urethra.
That's correct.
So just how does it sit for the urethra?
Yeah, so that's a great question. So there's cold water that is running through the probe itself. So there's about a 3 millimeter margin around the urethra. So we don't treat any cancer that's within 3 millimeters of the urethra, or don't expect there to be good treatment because of that cold water that's going through the probe. There's also endorectal probe that has cold water going through that as well. So it's sort of cooled. Both probes are in. Yeah.
What kind of anesthesia?
General. So it requires full paralysis because the MRI thermometry is measuring temperature on the molecular shift level. So it is, or atomic shift level. So it requires complete paralysis. Yeah, but that's it really is just for the measurement. There is someone in Georgia who does it with conscious sedation. He says that he's able to keep people motionless enough to do it. So looking at the different technologies we have here at Yale, just a quick comparison, because I know that was a lot of information. But so HIFU, it has many studies. It's very easy to do in terms of from a user pickup kind of standpoint. The software is self-directed. We do not currently have one here, but we're working on getting the Focal One device and anticipate it being available for any of my colleagues who are interested in using it if they wanted to. Limitations are limited by calcifications. There can be some prostate swelling with the heating. It cannot reach the whole gland, and there's sort of this thermal drift, which is sort of the term for heating outside the area that you want to treat. Now with updated technologies, doing what we call a double tap, if you get into the HIFU literature, is basically a double treatment of the area that you're concerned about with the cancer. They have much better oncologic control. There was some concern with a single pass. There's some studies published from Chicago, et cetera, where they had about a 60% recurrence rate. That was new users, and there are a lot of caveats to that. But with improved technology, it typically is done focally and in primarily the posterior part of the prostate. TULSA as a HIFU-based treatment. It's done from the urethra, as we were just talking about. The treatment planning, guidance, and tracking are unparalleled. So it's definitely the industry leader in terms of the ability to map out a tissue and real-time tracking and treatment monitoring. The limitations are calcifications in the prostate, again, some thermal drift. The biggest one is practical from a user perspective, that has to be done in the MRI scanner. So, for example, right now, we are allocated 3 days a month to do these procedures. As a result of that, our next available case is in June. So we have a tremendous amount of interest. We have a great team. We just don't have the capacity to do as many of these cases as there is demand. It can be done for focal and whole prostate. It can treat anterior and posterior. One of the other side benefits of technologies like TULSA that can treat the whole prostate, by being inside the urethra, we have about a 3 centimeter radius from the urethra that we can treat. But that includes a large part of the BPH part of prostate. And so we've actually seen a significant improvement in urinary symptoms in a lot of these men who are doing a whole prostate treatment. That's one of the potential uses of this therapy in men who have significant BPH and a prostate cancer. We can treat the cancer focally, but then also get rid of their BPH while they're there as a significant secondary benefit. Cryoablation, one of the oldest and has many studies. One of the challenges has limited visualization. If you have a really good high quality ultrasound, that helps a lot, but most of us don't. It has a large treatment margin, and with whole gland or bilateral treatment near the nerve bundles, it has a very high rate of erectile dysfunction. Some of the published data suggests about a 90% ED rate with whole gland prostate therapy. Some recent trials, though, it's probably about 50%, but it's not insignificant. So you can treat focally or the whole prostate. We use a cryoablation for whole gland salvage therapies a lot in men who do not have concerns about erectile function. But it can treat all of the prostate, but is really good at treating anterior parts of the prostate because you don't have to worry about your margin there as much in terms of collateral damage. So IRE is our sort of final needle-based program. So as precise ablation margin, has the question of improved nerve regrowth, as I mentioned. It's very good at, you can treat across the urethra. So for patients who have lesions abutting the urethra or of a recurrence after a previous treatment where we think there's a halo around the urethra with radiation therapy or after a TULSA, this can treat across the urethra with minimal damage, which is a great selling point. There's no embedded planning software at this point, which makes it somewhat challenging. It is user dependent in terms of needle placement and efficacy of treatment. And at the moment, there is limited insurance coverage. I guess I can talk about this now. So in terms of insurance, HIFU has had good reimbursement since 2015 or 2016. TULSA got a CPT level 1 code in January of this year. So it is now covered by all Medicare and Medicaid, which is a huge push forward. There has been a limited amount of private payer coverage, but that is expanding now that it has a CPT-1 code and coverage by Medicare and Medicaid. Cryo has been covered, continues to be covered. IRE, Medicare in Connecticut doesn't like it or doesn't cover it. Although it has been assigned, it is being assigned a CPT-1 code in January of 2026. So they have enough preliminary data. They have a clinical trial that has completed and is probably going to have publication or presentation at AUA with the expectation of potentially better insurance coverage starting later this year after that publication. So what is the post-treatment management and recovery for these patients? As the residents, I know you guys are like, well, what's Dr. Sprenkle doing? What do I do with these patients? So they're general anesthesia for pretty much all of them currently with the current technologies. It's an outpatient procedure, which means they go home the same day. The Foley catheter stays in for 1 week. That's largely because there's some swelling of the prostate and the few cases of rectal fistula that resolved with catheter drainage were in men who went into retention after their ablation because I took the catheter out on the first day. So just to kind of minimize that risk, I leave a Foley in for 1 day. They can return to full activity with their catheter on post-op day number 2. So as much as they can be fully active with a catheter, but there are no real limitations to their activity otherwise. And then follow up 1 week later, do a void trial at 1 month. I typically will see them in the office, do a PVR, Euroflow, check a first PSA and urinary and sexual function questionnaires. And then every 3 months for 2 years, when an MRI and biopsy at 1 and 2 years. And the MR and biopsy, that is sort of the current standard because these are still technically considered investigational therapies. There's a tremendous increase in the amount of information we have about them, but we are still following them very closely on protocol. So how do we choose which treatment? We're gonna review sort of the guidelines, some of the anatomic considerations, and then quality of life considerations. Okay. So according to sort of a few different guidelines, we can look at the EAU, AUA, and ASTRO, and sort of Falcon is a consensus, expert consensus statement, so it's not necessarily guidelines. But low risk disease, we feel that active surveillance is really preferred. And that is across the board. I strongly agree with that. I tell the residents as we're discussing patients, I do not treat Gleason 6 prostate cancer. You know, you can get people with a higher PSA. I don't think PSA is adequate. It is driven by the Gleason score. There is very good evidence that Gleason 6 does not metastasize. There's a whole discussion about whether or not we should even be calling Gleason 6 prostate cancer. So I can sort of, for me personally, that's not just low risk, that's anyone with Gleason 6 prostate cancer. Intermediate risk disease, the EAU suggests a trial setting or registry, since most of the treatment that is done there is part of those registries. That is not unusual. The AUA and ASTRO guidelines said select and informed patients can consider ablation therapy. And the Falcon consensus, which was a bunch of experts on ablation, think absolutely we should be treating patients with intermediate risk prostate cancer. High-risk localized disease and locally advanced disease, not currently recommended ablation therapies. I think this is potentially going to change. There was a Focal Therapy Society consensus paper that reviewed whole gland cryoablation. And in their review of all of the data, they actually found that for select patients with high-risk disease who either could not or refused to have standard therapy with surgery or radiation, ablation actually would be a very reasonable consideration given the successful destruction of tissue locally. So what about anatomic considerations? This is just knowing your prostate. What are the things that we are in the prostate or around the prostate that we need to be worried about? We talk about this in surgery and radiation. It's not particular to ablation therapy. It's really how do we approach prostate cancer patients. So the neurovascular bundles, right? Those are what sends signals from the brain to the penis to help men get an erection. You guys probably all know the physiology, but it is a threshold effect, right? So a certain amount of signal has to get from the brain to the penis. And Dr. Honig and Foster, you guys can correct me if I'm wrong on this, but it's a threshold effect. You have to get a certain amount of signal. So when you damage the nerves, if you damage one nerve, they still maybe have enough signal on one side, or even Ellen could correct me, it looks like. All right, she's shaking her head. But you need to get enough of signal. So PDE5 inhibitors help augment that. But we really want to sort of stay as far away from these nerves as we can. The urethra, mostly related to rectal urethral fistula. We don't want patients to have urine sort of in a cavity within the prostate or potentially causing an infection. That's typically what drives fistula, is an infection in the area in the posterior prostate or outside the prostate. The external sphincter, so urinary incontinence, the bladder neck, urinary urgency, not necessarily continence, but a lot of urinary symptoms can occur if we sort of affect the bladder neck, and the rectum. Another major thing that we don't want to impact, given a risk of rectal urethral fistula, which is just a devastating complication. And then also, what zone is the cancer in? Is it anterior or is it posterior? It's a very simple way for us to kind of think about approaching treatments. So again, this cancer is this one small lesion in the left posterior lateral near the nerve bundles, and this right anterior, which is a little farther away and may give us a little bit more safety margin. So how do I think about this? So patient gets a biopsy. They could have grade 1 through grade 5. For grade 2 disease, I mean, I now honestly get to decipher in almost everyone because there's good evidence that even in high-risk patients, it can impact whether or not they're going to need hormone therapy if they go on to radiation. There's not good evidence, but I still use it to determine the extent of lymph node dissection for some of these men. But for intermediate grade group 2, decipher low or high. If they have low decipher and grade group 2, they're going on active surveillance, as are all of my grade group 1 patients. If they have decipher intermediate or high or grade group 3, those are candidates for ablation. So it doesn't mean that they're going to get ablation, but they are definitely candidates. Question then is the cancer unifocal or multifocal? Can they have a focal therapy, or do they need treatment for their whole prostate? If it's unifocal, then anterior, posterior. So this is just stepwise, just it gets to be fast. But if it's anterior, I prefer cryo because it's really easy. I know it's covered by insurance. I'm not worried about damaging the nerve bundles for people who are worried about that. IRE can be done. TULSA is also very good anteriorly. Focal laser ablation, which we don't have, can also be considered. If it's posterior, all of these, other than I typically don't do cryo if a man has erectile function and wants to, and we're going to talk about that some more. If it's multifocal, surgery, radiation, whole gland cryo, whole gland TULSA. Gosh, I don't remember who was with me, but recently I did a few bilateral IRE cases. Those are long, which is why I don't have it listed here as recommended. But for men who have bilateral disease, who really are concerned about preserving their erectile function, it is an option. It's hard for me. It's not hard for them. They're asleep. So, I think it is a very reasonable thing to consider. So some of you might have seen this before. I mean, I have this discussion with patients. There are 4 buckets. There are 4 things to consider when deciding what kind of treatment is right for you. What is most important? Thinking about survival. Is cancer control sort of the ultimate most important thing to you? It's important for everyone, but they're differentiators. Sexual function, urinary continence and symptoms, and then bowel and bladder function. And I sort of say this to patients, like, how you got to think about this and make a decision. I can't tell you what's the right treatment for you. You have to grade these yourself and figure out what is the rank order for them. So with prostate cancer decision-making related to survival, we think surgery is the best because we're surgeons, right? It's going to have the best cancer control. It definitely is getting rid of the most prostate tissue and prostate cancer. We don't think it is different in terms of long-term outcomes, especially intermediate risk disease, than radiation therapy. And the ablation therapies are thought to be sub to that, and they are by definition. We are leaving prostate tissue behind when we are doing ablation therapies on purpose because we are prioritizing quality of life over a possible benefit in survival. So I think it's important to first say, how do we define cancer control? So as I mentioned, we're doing biopsies in all these patients. This is really part of the ideal criteria. I'll drop in the middle there first. Biopsy is an early safety endpoint. We're doing this to make sure that these technologies are safe, that we're actually having some effect on the cancer. We're still doing the biopsies because we're gaining that long-term information. If we look at actually radiation oncology, they did biopsies initially before they came up with the Phoenix criteria and biochemical recurrence of being 2 points above nadir. When they were doing biopsies, 40% of their patients had positive biopsies. They decided, shoot, that's kind of scary. Like, we don't necessarily need to have that be an endpoint because it's not clinically relevant for the majority of patients. I have a feeling that biopsy after ablation therapy, as we get more comfortable with imaging and other follow-up, is probably going to go the same way, but we're not there yet. So we're still biopsying all these patients. But when you see the data, just recognize that this is an intermediate endpoint. It's not necessarily the best one. Overall in cancer-specific survival, that would be perfect, right? That would be great, but that doesn't happen in prostate cancer, especially in localized prostate cancer that's lower intermediate risk. We just don't get there for a long time. Metastasis risk. So this actually is a very interesting one. I think this will probably be relevant in the focal ablation space. I'm going to talk about the PROTECT trial in the next slide, and we'll kind of see that they're probably measuring that difference in metastasis risk could be real, although it is going to take a lot of follow-up as well. And finally, salvage-free survival. So this is the kind of default therapy endpoint that we have come to in the ablation community. And it's what is the rate of whole prostate salvage treatments with either surgery, radiation, or ADT. And that's kind of a common funnel point for all of the therapies, right? If you had surgery, you have failure, you're going to have radiation or ADT. If you had radiation as your primary treatment, you're going to have a salvage whole cryo, or you're going to have a prostatectomy, or you're going to start ADT. So we've been using that really as one of the outcomes to differentiate. So as I mentioned with the PROTECT trial, I mean, it's hard to see anyway, but there is no difference there in the prostate cancer specific survival. This is out 15 years now, whether men were randomized to surgery, radiation or active monitoring at the beginning. What we do see, though, is in metastasis-free survival, there is a slight separation by those 15 years. So that's why I mentioned, I think that if ablation therapies, they're not going to probably swing that cancer-specific survival. How are we going to see a difference, right? If we don't see a difference between observation and treatment, how is ablation therapy going to be any different? So it's not a great endpoint for us to differentiate. But a 14% risk of metastasis within 15 years, I mean, the goal would be with an ablation therapy to have similar cancer-specific survival, because it's not going to be different. But if we can reduce that rate of metastasis in the future, that would be a win in my book. So let's look at some of these oncologic outcomes that exist. I just cherry-picked a few studies. One of the big differences over the last few years is there are now a tremendous number of reviews, and the number of articles that have been published in the last few years is staggering on ablation therapy. But looking at a few, there is a review that was published in 2022 looking at studies from 2015 to 2020 and across all different types of ablation therapy, and the 1-year biopsy freedom from recurrence, so this is a biopsy endpoint, was greater than 80% for grade group 2 or higher prostate cancer. And that's kind of accepted. That's what we think of. There should be 20% or less recurrence of clinically significant cancer in the prostate. A whole prostate ablation, so using either cryo or HIFU. This was the Focal Therapy Society position paper that was just published in European Urology. For whole prostate, a biochemical recurrence, so that was using a PSA endpoint, was about 30% at 5 years. And 5 years freedom from recurrence was 23%, against a biopsy endpoint. Looking at partial gland cryoablation, this is a very recent publication from Herb Lepore at NYU and their group, looking at over 300 patients who had a partial gland cryo. At 5 years of follow-up, only 16% required salvage treatment. 4% of those just had treatment without having a biopsy upgrade. They just decided they wanted to have treatment. And all of those patients had grade group 2 before treatment. So this is a full-on intermediate risk population. It's not a mix of low risk and intermediate risk. So, how do we compare to surgery? I mean, we have such long data with surgery. I mean, I just picked the MSK nomogram, which is similar to the Parton tables. But if you take a 65-year-old man with grade group 2 disease and 3 out of 13 biopsy cores, PSA of 6.5, you put him into the nomogram, his risk of BCR at 5 years is 17%, right? That's pretty similar to what we're seeing with a partial gland ablation. Like listen, I know it's apples and oranges. These are not head-to-head or randomized studies. That's all the data that we have so far. But looking at the TACT trials, that was a Tulsa trial, comparing it to Pivot, Capture, several PCAN studies. This is all about the same, with a need for a salvage therapy by 5 years across the board is around 20%. There have been some small studies, single center studies, that have tried to compare different treatments. This one looked at HIFU and prostatectomy, similar salvage-free survival at 5 years. Cancer-specific survival obviously is very high, and overall survival sort of delineates that some of these HIFU patients probably weren't candidates for surgery because they were too sick. There were then some propensity match score trials looking at about 1,300 patients. They pooled them in entry criteria, then in propensity matching based on age, neoadjuvant treatment, pretreatment PSA, et cetera, for about 250 patients in each of those groups. If you look at the matching, it's very good. And when you look at the outcomes then, sort of the block there in the middle, there is no statistically significant difference in failure-free survival at 3, 5, or 8 years. And I mean, in this study, the focal therapy patients actually did a little bit better. But I mean, I think that's, you can't say anything about this because these are propensity scored matches, not a head-to-head trial. So there is a head-to-head trial. We are actually part of this trial. It's the CAPTAIN trial, which is using TULSA. Patients are randomized to TULSA versus radical prostatectomy. We've had some success recruiting. It is a challenging trial to recruit to because you are asking patients to be willing to be randomized between surgery and ablation therapy. If they're interested in ablation, they're typically interested in ablation. They don't want surgery. So it's been a challenge. I think we have over 200 patients recruited as of the end of last year. There were sort of in the final 20 to round out the cohort, and we're hopefully will be done by the first quarter of this year. Any questions about cancer control comparisons before I move on? All right. So sexual function, impact on sexual function. We know that this is from the PIVOT trial, or sorry, PROTECT trial. So in addition to looking at the survival data, they did quality of life outcomes, looking at this is for the first part of the study publication out about 6 years. You can see the observation. So these patients, about a third of them had ED initially, even at the beginning of the trial, but there was a decline over time, even in the patients on observation. Big decline after treatment for the radiation group and the surgery group, but surgery has a significant negative impact on erectile function, and we've seen this multiple times. Now, if you do bilateral nerve sparing, you have excellent surgeons like Dr. Kim, you can get back to pretty good recovery of erectile function. So his rates here look like they're up to about 76% in people who have completely excellent sexual function. But again, just the caveat here, these are patients who have bilateral nerve sparing. How often are we actually doing bilateral nerve sparing? How often is the tumor in a location where we can actually do that? And so I think that this shows what can be possible in the right hands. But if you look at the previous study, that is an all-comers with multiple surgeons. We all want to be that we all think we're the greatest surgeon, but it's no one's average, right? If we look at TULSA in terms of sexual function, an ablation therapies, the impact on erectile function is directly related to the amount of tissue that you're ablating. So as we ablate more tissue, so along the bottom is the planned ablation fraction. So this goes up to 100%, so whole prostate treatment, going outside the prostate, treating everything. We see a steep drop off starting at around 85% of prostate volume, where it has a greater negative impact on erections. We've seen this in other studies looking at unilateral versus bilateral, just looking at a few others. IRE, one is a combined study with IRE, cryo, and HIFU. The patients who have erections adequate for intercourse is much higher, in the mid 80s up to 90%. This seems to be quite reproducible, and this is also, again, with all locations in the prostate, including ablation near the neurovascular bundle. The graph on the right is looking at partial cryoablation. They saw a dip in erectile function at 1 month. That was the only one that was statistically significant. But by 6 and 12 months, they were back to their baseline, if not above, in terms of their EPIC sexual function domain questionnaire responses. I didn't put it up, but in this study, they did look at location of treatment. So treating an anterior lesion with partial cryo has a much less impact on erectile function than you get with a posterior lateral treatment. Any questions about erectile function impact? Okay. Urinary continence and urinary symptoms. So, we can't get away from urinary incontinence with surgical procedure and the robotic prostatectomy. This is, again, the PIVOT trial. They found it out around, by that 6 years, still almost 30% of patients were using pads. That's high. I don't know if people have seen the PACE-A study, which showed almost a 50% use of incontinence after surgery. I think that's much higher than our individual experiences here in the United States, and definitely the surgeons that I know. These are modifiable. We have some internal data that we've submitted for publication that membranous urethra length and different surgical approaches can impact this. There's been a lot of studies looking at different approaches to help improve surgical outcomes in terms of continence. But if we look at ablation therapies, you can't get much better than this, right? 100% no pad use, 100%, 98.8%, 99%. Not just incontinence, but looking at EPIC urinary domain function after a partial cryo. There was a dip initially that typically is urinary urgency. It's not usually incontinence. It's usually urgency and some frequency due to irritation from the ablation. But patients are back to baseline by 3 months and then staying typically pretty steady. As I mentioned, with things like TULSA, we can actually see improvements in those domains for patients who have significant BPH symptoms initially. All right, so I'm not going to talk much about this because it's really related in terms of bowel function. That's primarily, sorry, that got cropped, related to radiation therapy. But with surgery, radiation, there's actually an increasing risk of toxicity in terms of hospital admissions, other urologic procedures, rectal anal procedures, open surgical procedures, and secondary malignancies after these invasive therapies. So which is most important? Oops, don't have the right slide there. So talk to your patient, right? So who knows? You don't know. That's your patient's decision. That's not for us to tell our patients. So they have to figure it out. And based on their age, their sexual function, their urinary function at baseline, the cancer location, all of these things can come into play. So who is a candidate? So we follow the guidelines, men with intermediate risk prostate cancer, anatomic considerations. Is it near a structure? Is it anterior, posterior? Is it near one of those neurovascular bundles? And then the quality of life considerations are very important. You have to talk to your patient. This is kind of a summary of that. I'm going to keep moving, but you know, what the patient wants is the most important thing. And so they kind of need to understand these differences between the technologies. We have a toolbox, right? And here at Yale, we have a really big toolbox. We have great radiation oncologists, we have great surgeons, we have these ablation therapies. So it's important for patients to know what the different benefits are and what they can do. And interesting, I thought this was a really important study, is actually talking to the patients, right? We sort of think that we know what they want, but we don't. And patients with low and intermediate risk prostate cancer actually preferred active surveillance to definitive therapy. I think this is pretty well accepted now, but in 2020, that was novel. And patients at all risk levels were willing to trade cancer-specific survival for improved quality of life. All risk levels, high risk cancer, low risk cancer, throughout.